This talk is on the affective disorders in the brain. They are very common disorders that are often missed or misdiagnosed, if diagnosed at all. And it results in a lot of unnecessary suffering, pain, and even death. And a number of even medical practitioners do not appreciate some of these symptoms, as a result of which the diagnosis is missed. And what I'm trying to do is to make sense out of some of the symptoms that are commonly presented and dismissed as no explanation. In other words, either a diagnosis of neurosis or imagination is made, neither of which are accurate. There is neurology, the study of the nervous system, that's the brain, spinal cord, and peripheral nerves, and psychiatry. Now, these disorders fall in between the nervous system and psychiatry. And it is this gray area that produces confusion in the diagnosis. The bottom line is a failure of electrical conduction down millions and millions of nerve cells. You know, there are not millions, there are billions of nerve cells in the brain which talk to each other. They are in continuous communication with each other. And I'll deal with that in a minute. But if that communication ceases, there is a block, or in technical terms, an interneuronal block. That is a block between two nerve cells, two or more, in a particular part of the brain. And in the affective disorders, it's an area of the brain called the limbic system. And we will see the limbic system in a minute. But first, let me demonstrate to you what electrical conduction in the nervous system is. Now, here are two bits of wire. This is one nerve cell, and that's the other nerve cell. If the nerve cells were touching, as so, then there would be no problem. The problem is that they are not. They are separated. Now, when they are separated by a hundredth of a millimeter or by a centimeter, it makes no difference. The electricity cannot jump across from one electrical wire to the other. In other words, from one nerve cell to the other. So, if electricity comes down that wire and the next wire is here, then there's got to be an electrical conductor, such as mercury, between the two cut ends of the wire, if the current is to flow. In terms of nerve chemistry, there has got to be a neurotransmitter, or, as is the case in these disorders, neurotransmitters, more than one neurotransmitter, for the electrical impulse to go across. Now, this is so important that I want you, but watch that slide which is now being shown. And I'll read it with you. It's affective disorder is a chemical stroke electrical disorder in the midbrain where the nerve cells stop talking to each other. The cause of the problem is unknown. Physical and emotional trauma, virus infection, stroke, surgery, and many other insults to the brain may trigger these nerve disorders. They are trigger factors, not causes. It results in a disturbance of nerve transmission, which we will go into in a minute. It can be corrected by chemical, stroke, electrical methods of treatment. Now, as the first line says, it's a chemical or electrical disorder. As such, it can be corrected by chemical and electrical methods of treatment. You know, it makes sense, and the essential thing is to make sense out of all this. Otherwise, it will not be accepted, nor will the diagnosis or the treatment. The important take-home message is that it is a biochemical disorder and it is not all in your head. Limbus is the Latin word for edge, and that is the emotional and memory center of the brain. You can see it there in red, and we'll go into that in a minute. Here is the limbic system in detail, and there are a whole lot of terms there: nucleus accumbens, ventral tegmental area, hippocampus, the locus coeruleus, amygdala, etc. You don't need to know all these because they are Latin terms which will not make any sense to you. If you want to read the writing in red, which is not necessary, you can pause this DVD and read it. Now, what is important is that the hippocampus, locus coeruleus, and the amygdala at the base of the brain, they control critical emotional problems. We see more of this. The cingulate gyrus, that again is another Latin term for cingulate equals girdle. The thalamus, hypothalamus, amygdala, hippocampus, mammillary bodies that control memory, and the fornix. Now, here is some information that has just been released from Massachusetts, and that shows the wiring of the brain. I mean, it is remarkable. There are billions and billions of wires, and these are now being mapped out, and the project will take at least 5 years and cost millions of dollars. Here's a cross-section of the brain, and there you can see those green bundles. That's from that locus, the cingulate gyrus, and they connect up with the frontal part of the brain and serve the executive function in conjunction with the hippocampus, which is the center of memory. Those large red bundles connect the left side of the brain with the right and vice versa. Now here is nerve transmission. You can see the electrical impulse coming down that nerve cell and liberating a neurotransmitter. In fact, neurotransmitters, several of them, there are about 50, but of clinical importance are about 4 or 5, and they are picked up by the next nerve cell, which you can see as a cup. Now, the important nerve transmitters are serotonin, they're right at the top there, gamma-aminobutyric acid, noradrenaline, acetylcholine, and the neuropeptides, which are called, interestingly, multilingual chemicals. They are called multilingual chemicals because they talk to each other. The chemicals that are transmitting the message recognize what language the nerve cell will recognize and then convey the electrical message in that manner. I mean, it's quite remarkable, the whole business. Serotonin is one of the main neurotransmitters in the brain. Now, here is what happens in affective disorders. You can see the nerve electrical impulse coming down that nerve cell, and then it gets on to the next nerve cell. Now, in these affective disorders, that doesn't happen. The electrical impulse comes down, the neurotransmitter is secreted, and then it turns around and goes the other way around. The result of all this is a disturbance of nerve transmission. The nerve cells stop talking to each other. Now, how do these people present? Here's the presentation. The textbook presentation is of someone with tears rolling down his cheeks. If you can get him to say anything, which you often can't, it's of worthlessness, thoughts of dying, and whether the planet Earth would not be better off without him in it. Now, that sort of presentation, for sure, that person has an affective disorder, but that sort of presentation is rare. The much more common disorder presentation is a person who looks you straight in the face, and as the slide says, tells you some real sounding symptoms. Doc, I'm fatigued, or I got a headache, or I'm feeling run down, give me a tonic. If it's an old lady, the usual punchline is, Doc, what vitamin do you recommend? I will describe to you 4 people whom I have taken from my practice, whom I have seen. First is a 40-year-old man whom I call Charlie, the garage mechanic. He has serviced my car for many years. I've known him to work till 6 o'clock, 6:30 in the evening, no grumbling. Recently, when I've taken in my car for service, at 4 o'clock, Charlie's gone home. 3 o'clock, he's gone home. 2 o'clock, he's gone home. 1 o'clock, he's gone home. And you ask, where's Charlie? He's gone home. Why? Because he's tired. I thought it fairly unusual for Charlie to do that. And I said, well, has he seen a doctor? He said, oh yeah, he's seen a doctor. And the GP said that he was short of thyroxine. There is a secretion coming from the gland in the neck here. I said, well, that's not a big deal. All he has to do, if he's short of thyroxine, is to take some thyroid hormone. He said, oh, I think he had done that. But he is no better. That's why he is coming to see you. So in walks Charlie, and here is the conversation. I said, hi Charlie, what's wrong? Nothing, doc, it's just this thyroid. There are not enough secretions. I said, well, why don't you take some thyroxine? He said, I am, doc. The endocrinologist gave me some and later checked the blood and told me I was fine. I said, then why have you come to see me? He said, because I feel no better than before I went on to thyroxine, indicating that the abnormal blood tests for the thyroid gland, the thyroid secretions, had nothing to do with his symptoms, which was fatigue. The second case is of Mary, who has been a cleaner in my clinic for years. I was surprised to see her name on the new patient list. And Mary came in. I said, hello Mary, what can I do for you? He said, I don't know, doc, why I have come to see you. My husband says I need a tonic. I said, where is your husband? He said, he's out there. I said, bring him in. And here is the conversation that occurred. Why do you think she needs a tonic? Husband, doc, all day long she says she had a headache. She saw a neurologist who did a brain scan and all the tests are negative. So, if all the tests are negative, there's nothing wrong with her. She needs a tonic or some vitamins. She probably needed neither, but a proper diagnosis. The third patient is an engineer who has had a distinguished record in engineering. He retired to Sydney, and there, after some time, he developed a shuffling gait and had a tremor, a slow tremor of the hand. Now these are the classic features of Parkinson's disease, which are the right diagnosis. He was put on L-Dopa, the correct treatment, and the shuffling improved a little, the shakes improved a little, but he did not feel well. He saw the neurologist who said, look, that's about as much as I can do for you. He said, doc, what about my memory problem? He said, oh, I don't know anything about that. You better see a psychogeriatrician, which he did. And psychogeriatrician said, well, it may be Alzheimer's. Gave him a course of treatment for Alzheimer's disease. He didn't get any better. The relatives asked me to go and see him. Now, I got no rooms in Sydney, so I opted to see him at his home, just as well, because as I walked in, the diagnosis was almost there, right before my eyes. I saw a number of paintings and sculptures, some done and some partly done, that's partly unfinished. And I said, who did all these? He said, I did. And here is the conversation that followed. I asked, as I said, who did these? And he said, I did. I said, you are very talented. When did you do all this? The patient said, oh, that was a long time ago. And I said, don't you do any paintings or sculptures anymore? He said, no. I said, what's the problem? He said, you know, it's Parkinson's disease. I said, put that in actual terms. What part of Parkinson's disease? Is it the shakes? Because if it is, I can do something about it. He said, no, the hand is perfectly steady. But then he made the crucial statement, which gave me the diagnosis. He said, I don't feel like it. These are the patients with affective disorders that are seen and missed by doctors, including specialists such as myself. You miss the diagnosis, you can deny the patient treatment that will transform his life. And if you miss the diagnosis in children, which you can because this disorder also occurs in children, you can throw away his or her entire career and even lead to suicide, the dreadful results of which I will show you in a minute. Okay. What are the symptoms? I have this chronic fatigue syndrome. Fatigue is the presenting feature. I have this chronic fatigue syndrome. You know, I'm sure that there are patients with a fatigue syndrome, but they are rare. The vast majority of patients with a chronic fatigue syndrome, or so-called, have a variant of this disease rather than some nebulous entity for which there is no treatment. Or I have ME, myalgic encephalitis. And why do you think you got ME? Because the Women's Magazine or whatever journal you read says these are the symptoms. Well, again, myalgic encephalitis did occur in epidemic form back in the 1950s. I don't think there has been a case or epidemic since. There are occasional cases for sure, but certainly most of those patients with so-called ME are variants of this disease, which is eminently treatable. Pain. Pain anywhere. Pain in the head, headache, pain in the back, pain in the joints, pain in the muscles, pain in the limbs, pain in the abdomen. For sure, you got a guy with pain, that sudden onset of pain in the head. He may have a bleed inside his brain, especially if he's at a fall, or in an elderly person, even without a fall, you can have a bleed in the brain. But if the brain scan is normal and every other test is normal, before you dismiss him as a neurotic with a headache that he really doesn't have, think on the possibility of one of these affective disorders. This is not the sweet old lady who wears pain like a badge. I got pain here, doc, here, here. Now what's causing the pain? Here, doc. Now that's a patient who uses pain like a badge. You can give that patient a kilogram of these medications. It's not going to make a jot of difference. There is a way of handling such patients, but drug therapy is not one. Memory problems. I have Alzheimer's disease, I think. Or is it my age, doc? It probably is neither. It is probably a variant of this disease. I don't see that every person with a memory disturbance has this disorder, but a fair few have. Some of them have Alzheimer's, without question, but a lot of them don't, or at least some of them don't, and they are being denied very effective treatment. Gastrointestinal problems, the irritable bowel syndrome, diarrhea and constipation, alternating diarrhea and constipation. Now for sure, anyone, especially someone over the age of 40, develops alternate diarrhea and constipation, you've got to think of the possibility of a cancer of the colon. But after the colonoscopy has been done and repeated to see why this guy or person has alternate bowel diarrhea and constipation and a bowel disturbance, and find everything normal, before you say that there is nothing wrong with the patient, think of the possibility of an affective disorder, which a lot of these patients do have, including those with the irritable bowel syndrome. Patients sometimes come complaining of simply feeling unwell. I'm not feeling well, doc. Can you put that in better English? No, I can't. Being unwell is unwell. It's like that post-flu syndrome, where you have got the flu, you recover from the flu, but you're not feeling your normal self. There's a sleep problem in almost all these patients. The classic sleep disturbance is getting to sleep at whatever time you get to sleep, 9 o'clock or 10 o'clock, and then getting up at 1 o'clock, 2 o'clock, 3 o'clock without the dog barking, and you toss and turn, and then go to sleep again, and then you wake up again, and this goes on till morning, and you wake up feeling unrefreshed. Unrefreshed sleep should alert you always to the possibility of one of these disorders. Then there is the rarer person with a difficulty in getting off to sleep. These are the patients who get all sorts of sleeping tablets, temazepam, mogadon, Valium, all of which incidentally are drugs of addiction, when the real diagnosis is one of these disorders which you can treat with drugs that are not addictive. Then there is a younger patient who does not have a difficulty in getting off to sleep but sleeps all night, and if you give him a chance, he sleeps all day too. He is the person who wakes up in the morning, has his breakfast, and then says he wants to go to bed again. If it's a schoolboy or schoolgirl, they wake up in the morning, they don't want to go to school, saying, I really feel sleepy. They are forced to go to school, they go to school and then fall asleep on the table. And they are chastised for that, when they are really suffering from one of these very treatable diseases. Anxiety and irritability. Doc, can you give me something for my nerves? And the usual mistake is to give them some Valium for the nerves and make them Valium addicts, which if you take Valium and all the benzodiazepine tranquilizers for long enough, you will get addicted. They are only half-brothers of morphine and heroin. Weight gain and weight loss. Weight gain, the appetite increases, weight goes up, end up with obesity, and then all the way to morbid obesity, which has a quite definite higher incidence of strokes and heart attacks in particular, and particularly type 2 diabetes. Or weight loss, they lose weight, they get emaciated, and they end up with anorexia nervosa, which again has a death rate. Or the patient can be brought with no symptoms. You can see, brought by relatives, saying that he is not his normal self. He's a guy who used to be the life of the party, go out, play bowls or whatever people do, but now he's either watching television or he goes and has a nap, and that's quite non-characteristic of him. Those are the sort of patients who should alert you to the possibility that you are missing this group of disorders. How do you make the diagnosis? There are three things that should alert you to the possibility of an affective disorder. Firstly, sleep, fatigue. If all the tests are normal, the thyroid test is normal, the blood chemistry is normal, and before you end up saying that he is fatigued for no reason, think of the possibility of an affective disorder. Secondly, a sleep disturbance, which I have already gone into before, either difficulty in getting off to sleep, difficulty in remaining asleep, or waking up unrefreshed, or the oversleepiness. And the third is the patient who simply says he is not well. Let me give you three disasters. The first is a girl who had an outstanding record as a child. First year class prize, second year class prize, third year class prize. So we are not dealing with a dummy. Fourth year dropped off halfway down the ladder, the academic ladder. The next year was right at the bottom and had to repeat that year. Parents were about to take the child out of the school, saying, I don't know why we are paying these colossal fees for these private schools. We better take you out and send you to one of the state schools and make you into a checkout kid at the local supermarket. When a fill-in teacher noticed that something was wrong, it didn't all add up. If this child who had been doing so well, maybe the child is sick. Let's get him checked out. Sent it to me, and I checked the child out. I made a diagnosis of affective disorder and put her on the correct treatment. Grades came good, came to the top of the class, and I kept her on treatment for about a year and a half, and gradually tailed down the dose, which I will deal with in a minute. And I thought that she didn't need to see me unless there was a setback. And I told her, look, if you get pregnant, particularly postpartum, the whole thing might come back. Or if you meet with a road traffic accident, or have a major psychological trauma, or the roof falls down on your head, or you have surgery, or some such trauma, it might all come back. Then you'd know to get on the correct medication. Or you get to the menopause, it might all come back, and then you would know what to put yourself on, or get yourself put on. When I lost touch with her, I had gone to the local hospital where I had worked, mainly to show my face. I had gone for some lecture which was on, midday lunch lecture, and before the lecture there was just a informal lunch. I saw this girl sitting and smiling at me. After a lot of smiling, she came and asked me, he said, "You don't recognize me, do you?" I said, "No." He said, "Do you remember treating a girl in that private school near your surgery?" I said, "Yes, many years ago." He said, "What happened to that girl?" I said, "I have no idea." He said, "I was that girl." I said, "And what's happened to you?" He said, "I came to the top of the class, I got into medical school, I got a first class in medicine, and now I have passed the FRACP, that's the Fellow of the Royal College of Physicians, which is the top degree in medicine, and I'm in training to become a physician." And why we were laughing there is I was telling my mates there, he said, if not for that person, I would have ended up as a checkout kid at the local supermarket. Those are some of the tragedies that could occur. The next tragedy is a 17-year-old boy who could not cope with his work after doing extremely well, and he dated to an attack of glandular fever. Let me tell you about this tragedy. The parents, both of whom were known to me, called me, child was then about 16, can we come and discuss his career pathway? I said, what's there to discuss? He wants to do medicine. And could you tell us whether he will make it? Well, I saw the boy, I mean, you don't need a lot of medicine, intelligence to do medicine. I thought that he got the necessary motivation and the interest in the subject, he'll do all right. I said, I don't think there's a problem here. He can get into medicine, I'm sure he will. If not the first time, the second time or whatever. But he can do medicine. About a year later, I had a call saying that he had decided to drop out of school. I said, why? He said, because he reckons he can't cope. I said, look, the child may be ill. Why don't you bring him to see me? So the three of them came, father, mother, and the child. I took a careful history and made a diagnosis of an affective disorder, fatigue, loss of concentration, and we'll go over all this in a minute, lack of memory, etc. Put him on the necessary medication, and I said, well, see me in 2 or 3 weeks' time. Both father and mother were doctors. I didn't need to see them weekly, which I would have done, and I told them how to increase the dose, which I will go over with you in a minute, and see me in a few weeks' time. 3 weeks came and went, no child, no father, no mother. I felt embarrassed to call them and say, what happened? Because I thought they would think that I was short of money and I was trying to make some money on Medicare by seeing them. I wasn't. I should have, it was my fault. I should have actually called them to see what was going on. Sometime later, I was reading the local paper, the obituary columns. I was looking, I heard that a friend of mine had died of pancreatic cancer, and I was trying to see when the funeral arrangements were, when I saw this boy's name there. I called the parents at once and said, what happened? He said, the child met with an accident. I said, oh my goodness, these children drive far too fast. He said, it wasn't an accident like that. He said, can we come and see you? He said, of course you can. And then they came, and then came the story. What had happened was that they had gone, looked at the script, and despite all my explanation, which I will do in a minute, torn up the script and put it in the dustbin. Went to see another physician who said, now, I don't agree at all. He doesn't have an affective disorder or any other disorder. He said, but Doc, why is he fatigued? He said, well, he's probably been working too hard. Take him on a cruise. Well, father and mother, both doctors, money wasn't a problem, so they took him on a cruise to Vanuatu and Cook Islands and Fiji and God knows where. The boy came back feeling even more tired. Went and saw the physician and he said, well, Doc, he know better. He said, well, Rome wasn't built in a day. If you are genuinely worried about an affective disorder, I'll send you to a psychiatrist. And referred patient to a psychiatrist. Psychiatrist took a history and said, I totally agree with the referring doctor. He doesn't have an affective disorder or any other disorder. He said, but doc, why is he so tired? Why can he not concentrate on things? He said, well, people are tired. If you go out on the streets and talk to the first 100 people you meet, at least half of them, if not three-quarters, will tell you that they are fatigued. He said, he needs to socialize, have a barn dance or whatever you do to cheer him up. Well, they had not one dance but several barn dances. And after about the fourth, with the boy feeling more and more fatigued, he came home, parked his car, went upstairs, took his father's revolver, and that was the end of the road. He shot himself. That is an avoidable tragedy. The next case, or cases that I want to describe, is an 80-year-old. You can see there it is. The history is there. Third case, whose son-in-law dumped him in my outpatient clinic. He's a doc. For goodness sake, admit this woman. She's driving us nuts. Marriage is breaking down and she's really becoming impossible to cope with. I admitted her and took a careful history. You can't take a careful history with 50 people around you. The best time to do that is after hours, when all the crowd has gone away and there's peace and quiet. Come down and have a chat. I had a chat and I realized that she satisfied a lot of the criteria of an affective disorder. I put her on doxepin, pushed up the dose, at about 50 milligrams, 75 milligrams, she came good. And she was now not only washing herself, which she hadn't done for months, if not years. She hadn't made a bed ever, not in the last 5 years. She was not only helping to make the bed, but actually making her bed. I called the son-in-law and said, you still want me to send her to a nursing home? He said, no, not really, doc. I think we can manage. The last case is a 70-year-old man who recovered from a stroke. He had lost his right arm and right leg, and you'd say, well, you'd feel sad about that, wouldn't you? I said, of course you would. But if he is in a wheelchair, even if he is in a wheelchair, that should not prevent him from going out and meeting his friends. And the fact that he is refusing to go out and meet anybody, doesn't want anybody to come home either, means that there is something else in addition to the stroke that has jiggled his brain chemistry and put it out of sync. And this jiggling is what is the underlying problem in affective disorder. How do you manage these patients? Well, the first and most important thing in the management is a rational explanation to the patient and the family and the caretakers and everybody else involved with that patient's management. If you don't give a rational explanation, the diagnosis will not be accepted and the treatment will not be accepted, and you will lose that patient in terms of both diagnosis as well as treatment. If there is the slightest doubt as to an affective disorder, I opt to give them a trial of therapy. Maybe I'm treating people unnecessarily with medication. I would rather do that than to miss one of these and pay the ultimate price, which is suicide, and I'll show you the dreadful statistics in a moment. Here is what I meant by a rational explanation to the patient and the family. There you see the limbic system, the nerve cells talking to each other round and round, and then supplying electrical impulses to those little dots. Those dots are the centers which I showed you in those opening slides of the brain, the cingulate gyrus, etc. Now, I then show this slide and say, look, those top two are normal. That's the normal electrical impulse coming, the neurotransmitter has been secreted, and then I say, look, this is what has happened in you. The neurotransmitter has turned around and gone the other way around. The result is that the nerve cells are not talking to each other. Now, I tell them, here is the block in the limbic system. And if you block that, then the electrical impulses that come to the base of the brain, which you can see, the sleep center, the fatigue center, the center that controls mood, and memory, concentration, pain, all of them just stop working. The result is all these symptoms and more. I tell the patient, look, what has happened is simply that the neurotransmitter has come off, and instead of going on to the next nerve cell, has gone the other way around, as I have just showed you. Here is this is a very important slide because it shows many of the symptoms of an affective disorder. And I often show this even before I get the full history, so the patient doesn't feel that I'm making it up as I go along. I point out the sleep disorder, which is often the case of difficulty in remaining asleep, waking up at 1 o'clock, 2 o'clock, 3 o'clock without the dog barking, and waking up unrefreshed. The difficulty sometimes of getting off to sleep and of being oversleeping, sleeping day and night. Center for fatigue goes, the mood center goes, there's depression, anxiety and irritability. Actually, some 20% of people do not get depression at all. That's why I don't like to call these depressive illnesses, because if you do not have depression, how can you call it a depressive illness and make sense? And if you can't make sense, the patient will not accept the diagnosis. Concentration, memory, pain, I've dealt with that in detail. The bowel disturbance, again I've dealt with that in detail, as the diarrhea, constipation. The center for pleasure goes. And if the center for pleasure goes, you can buy him a Mercedes, you can take him on a world cruise, you can do what you like. If he has got no zing from it, it's not going to work. The center for wellness goes and people feel unwell. Doctors get worked up about it and say, what do you mean by unwell? Well, unwell is unwell. Appetite is up and or down. If it's up, it's obesity and the morbid obesity. And I've got an interest in obesity, and some of these patients who come to see me at 170, 180 kg, put them on a diet, if they're losing weight, that's fine. But if they get stuck, and despite being on a diet and exercise, nothing seems to happen, then I suspect that one of these disorders may be responsible, and put him on a selective serotonin reuptake inhibitor, which I will deal with in a minute, and often the weight loss will occur. If the weight is down and the patient's anorexic, then one of these medications is mandatory before the patient dies. Sex drive goes, patients are reluctant to talk about their sex drive for what reason I don't know, but if you ask them directly, they will tell you, often looking down, yes doc, sex drive has dropped off. The decision-making process goes. This is the center that tells you whether to go to the bank or the supermarket or not to go anywhere at all, to watch television or go and sleep or what. That decision-making process is one of the centers in the brain. Now, treatment. Well, the treatment's obvious. If the problem is a reuptake of serotonin and other neurotransmitters, the treatment is to block the reuptake of serotonin, which you can see on that slide. And then you will convert the diagram above to the diagram below. And once the neurotransmitter starts flowing, then all the centers start working and he comes good. Now, those are the treatment options. I'll go over them with you. Non-drug methods: sunlight and exercise. sunlight. There is very good evidence that sunlight works. How sunlight gets into the brain, I don't know, but there is very good evidence that it does. For example, Eskimos have this disorder far more commonly in winter than in summer, in winter where there is no sunlight. There are other experiments that have been done to show that sunlight, perhaps getting in through the pineal gland or some other way, sunlight does positively benefit these patients. So when you tell the patients that if they are relatives, and I tell the relatives about this too, encourage you to go for a walk in the sun. They are not trying to harass you, they are only trying to make the medication work. Secondly, exercise. There is very good evidence that exercise helps in rejuvenating the endorphins or the internal neurotransmitters. I qualified in England, and I can remember in that dreadfully cold country, people going for a run in 5 inches of snow in the sleet. And you say, are you crazy to go for a run in -5 degrees? They say, I don't know, I think it is crazy, but somehow we feel better. Drug therapy is the mainstay of therapy. I said in that diagram there, the tricyclics and the serotonin reuptake inhibitors. The tricyclics have been around for at least 60 years, if not longer. SSRIs have been around for a shorter time. They are both useful, and we'll go into the side effects and indications in a minute, but they both work if, in about 80 to 90%, if 1, the diagnosis is right, 2, the drug is right, the dose is right, you get adequate time for the medication to work, and the patient is compliant. What do I mean by compliant? I mean the patient takes the medication that I asked him to take. If I give him 150 milligrams of imipramine and he takes 10 milligrams, it's not going to work. Any more than if he has got a roaring pneumonia and he needs 20 million units of penicillin, if you give him 2 tablets of penicillin, it's not going to work, he's going to die. So you got to get the patient to take the medication as instructed. That will help. Here is the way the dose is increased. I'm generally quite conservative. I start the patient, say imipramine or amitriptyline or whatever it is, at a very low dose, 10 milligrams. I know it is homeopathic, I know it doesn't work. Then why do I give it? To test the waters. For example, if on 10 milligrams he has a rash, I'm not going to be mad enough to give him 25. I will stop it and give him something else. Just as much as if I give him some penicillin, test dose of penicillin, and he develops a rash or asthma or whatever, I'm not going to give him 500,000 units of penicillin and kill him. So if he tolerates the 10 milligrams, then I show this diagram and say, look, I would like you to push up the dose, 25 milligrams every week, 50, 75, 100, or, and I will see you every week and tell you how to increase the dose. Supposing I see him at 75 milligrams, and I say, well, John, how are you going? He said, well, doc, my goodness me, the drug's working. I said, what do you mean by that? He said, I have the best night's sleep I have ever had. And amitriptyline or all the tricyclics do just that. Produces an excellent night's sleep. I said, no, that's only one. How do you feel in yourself? You said that you're sleeping very well, but how do you feel? He said, yes, doc, sleep's fine, but I still feel tired. Well, if you're still feeling tired, you haven't even got your job done. So you push the dose up. Dose up to 100, 125, 150, and until all the symptoms are gone. If I am worried that I am giving him or her too much medication, exceeded the toxic level, I run off a blood level to see where we stand. Now there is some controversy in this area as to whether the blood level means anything. Whether you really want the level in his brain, isn't it? But I can't dig a hole and get a bit of brain out and see what the brain level is. So the best I can do is to get a blood level done. I do it because if the blood level is very low, then I'm comfortable pushing the dose up. But a better indicator of toxic level is the ECG in those taking a tricyclic. And there is an electrical change called the QTC interval, and if the QTC gets very prolonged, I then change over to something else. Now, the important thing to make, the point to make, is that once he feels better, as that diagram will show, he should not stop the medication. If he stops the medication, he will relapse with 75% of people. It's exactly like asthma. Supposing a patient comes to see me with roaring asthma, I give him 50 milligrams of prednisone, and the asthma will stop within a couple of hours. If he now stops the medication, he will relapse in the majority of cases in the next day. I tail off the prednisone slowly. In this case, as you can see from the diagram, you have to tail off the dose even slower. If you went up by 25 milligrams every week, you bring it down by 25 milligrams every month, or even slower. If at any point in time the symptoms reappear, he starts getting fatigued again, up he goes to where he was. Now the reason for that is entirely physiological. There you see the gut, arrow and 100, that's 100 milligrams coming into the gut, being absorbed. Now I want that 100 milligrams to go to the brain where the block is, but the blood flow doesn't take it there. The blood flow goes to the liver, which tosses out 80% of the medication. If you are putting in 100 milligrams, you'll be lucky if 20 micrograms gets into the blood and into the brain. That is the reason why you've got to gradually increase the dose. I'm often asked, well doc, the liver is tossing out the drug, is it damaging the liver? I said, no, it's the other way around. It's the liver that is damaging your attempts to get ahead of the liver to get enough into the bloodstream. The liver is damaging the drug, not the drug, the liver. And if you are in any doubts about it, I will run off a liver function blood test and show you that the liver is completely normal. If the liver is tapped out, say a patient with cirrhosis or an elderly patient whose liver is not crash on, then you can get ahead of the liver with relatively smaller quantities of drugs, say 50 milligrams of doxepin instead of having to use 150 milligrams. Now, if I'm talking to a lay populace that has difficulty in appreciating what I've just said, I say, look, think of the body as a bathtub. Now there you can see the bathtub. The floor is on fire. The floor is the brain. You got a tap, you don't have a plug, you don't have a bucket. The plug, the drain pipe there is the liver. You don't want to take the guy's liver out, he's going to die. So what do? You turn on the tap. 25 milligrams, 50 milligrams, it runs straight through the drain pipe. So what do? Instead of allowing the place to burn down, you then increase the flow. That is, you go from 75 to 100 to 125, 150, and there you can see that at about 160 nanograms, the water overflows and quenches the fire. That is the reason why you've got to increase the dose, as I've shown you earlier. It has all to do with liver clearance. Suicide. This is the most dreadful result of missing the diagnosis. Now I just want to show you these shocking results, which certainly shocked me when I first saw them. There are 1 million suicides worldwide. It's the 10th leading cause of death in the world. You get all worked up about coronary artery disease, so you should, because it is a common cause of death. But this is the 10th most common cause of death in the world. And we don't get, it's often due to one of these affective disorders being missed. It is for each successful, within quotes, successful suicide, that's for each patient who has died, there are 10 to 40 non-fatal attempts for every completed act. There are 10 million people seen in emergency departments across the world. It's a huge disease burden. It's a drain on the health dollar. Seeing these patients in emergency departments, 10 million of them, with a disease that could have been prevented, and hence the patient prevented from coming with an overdose to the emergency department. All of these figures, however dramatic they are and however shocking they are, I underestimate because many of these cases are underreported. If grandfather committed suicide by shooting himself, it was an accidental shooting. So it's entered in the books as accidental death. That nothing to do with accident, that was suicide. Here is suicide in the young. I don't know the figures for Australia, but I don't think they're much different. I know the figures for the United States. In the 30-year period from 1960 to 1990,